have seen the last class malaria, and today we will be continuing some more drugs. So we had just started quinine last class. So continuing with quinine. Quinine, it is obtained from the cinchona tree, and it is the levorotatory. Levorotatory alkaloid is quinine, whereas the dextrorotatory of the D isomer, it is called quinidine. And this levorotatory alkaloid is the one that is used for malaria, and the dextrorotatory of the D isomer, it is used as an antiarrhythmic. It can be used in some countries. It is used for malaria also, but the main quinine, it is the levorotatory, which is the one that is used in India. And it is an erythrocytic schizondicide, and it is more toxic than chloroquine also. So erythrocytic schizondicide, quinine. So we will again see more features, and usually along with this quinine, for the complete parasite clearance, we may add the antibiotics like doxycycline, clindamycin, etc. And it has no effect on the pre-erythrocytic stage or hypnosis. So that means it is not effective for the relapse cases. That is for the relapses that is occurring in the vivax, ovale, malaria, etc. So, but it is a gamete. So it is having schizondecidal property as well as erythrocytic schizondecidal as well as gametocidal property. It doesn't have any exoerythrocytic stage, no effect, so it cannot be used for relapse. So that is about then. What is the mechanism of action? Like chloroquine, yesterday we have seen chloroquine, it prevents the formation of this hemozoin, which is necessary for the growth of, further growth of this plasmodia. So chloroquine inhibits. Similarly, quinine and mefloquine, everything, it will prevent the formation of hemozoin because it prevents this polymerization, heme polymerization. So the quinine heme complex or the heme itself, it is highly toxic for the malaria parasite. So that is the action of this quinine. It has got some other actions also, locally irritant and anesthetic action. And also gastric secretion also will be increased. Pharmacokinetically, it can be given orally as well as IV also, and it is non-cumulative because chloroquine we have seen it is cumulative. It can be accumulated in the retina and can cause many problems, but the quinine is non-cumulative. Then what are the adverse effects? Adverse effects, it is dose related. That means we should not go for a high dose, or we should not go for long time therapy also, long time treatment. So such cases it can cause toxicity, otherwise it is a safe drug. And if you are taking 8 to 10 gram in a single dose, if it is taken, it is a fatal. And there is a condition called syndrome called syngonism. Syngonism, the drug is taken from cinchona bark. You have already seen. So the condition is called syngonism. This occurs when if we are taking a large single dose or higher therapeutic dose taken for a few days, and that produces a syndrome called syngonism. So what is the syngonism? What are the clinical features? See, first I will read it, then I will show it. It consists of ringing in ears, nausea, vomiting. It is due to both gastric irritation and CT chemoreceptor triggered zone stimulation, headache, mental confusion, vertigo, different problems, difficulty in hearing, visual defects. It is due to the direct neurotoxicity as well as the constriction of the retinal and auditory vessels. Then diarrhea and flushing and marked perspiration also can occur. So in short, it can cause sweating and flushing of skin. There's tinnitus. Tinnitus means there will be ringing in ear, and there will be blurred vision, confusion, headache. So these are some of the features. There is a clinical features. There is syndrome. That syngonism, it is a side effect of this quinine. It causes, if it is going for fatal doses or higher doses, high single dose, this causes syngonism. But once we stop the drug, it is reversible. So that this is called syngonism. Now another thing, this quinine can also cause hemolysis. That is not frequent. It is occasionally only in pregnant women, and especially patients with falciparum malaria. And the hemolysis means there will be when there is hemolysis, there will be hemoglobinuria. That is in the urine, hemoglobin, it is excreted. So that will cause discoloration of the urine. So these are the different urine, that is urine taken from the patients on quinine, and that is at 0, 12, 36 hours like that. So finally it becomes black color. So it is so it is called black water fever. It is not a fever. So because it is occurring in malaria and is happening after quinine, it is called black water fever. Black water. Water means it is urine only. And there will be a kidney damage. So this is one side effect of quinine. So quinine causes zingonism, as well as it can cause hemolysis, which may result in black water fever and kidney damage. Then, what are the uses of this quinine? Quinine, you know that it is used in, we are dealing with malaria. So it is used in the uncomplicated chloroquine-resistant malaria. See, if the malaria, it is the plasmodium, if it is sensitive to chloroquine, we will go for only chloroquine. But if it is uncomplicated and chloroquine-resistant, we can go for malaria orally, as well as intravenous also for complicated cerebral malaria. And yesterday I was telling, now for the uncomplicated resistant falciparum malaria, we will be people are using now the choice drug is artemisinin combination therapy. But alternative to this artemisinin combination therapy, we can use this quinine also. But the only thing, it is having a narrow therapeutic index, because we have seen high doses it can cause this zingonism, black water fever, etc. So it is only for the resistant malaria we are using, and it is a drug of choice during the first trimester of pregnancy. Then, yes, it is used. So it is used in the uncomplicated chloroquine-resistant malaria. Then it is also used in the complicated and severe malaria, including cerebral malaria. Sometimes the malaria, some people may develop cerebral malaria. And such cases, because this quinine, if you are giving intravenously, sometimes it can cause hyperinsulinemia, and that may cause hypoglycemia. So to prevent hypoglycemia, we have to give quinine in 5% dextrose. Then what is the cerebral malaria? What are the features? So it can cause fever, convulsions, then electrolyte imbalance will be there, acidosis extra will be there. So it has to be treated. Fever, we have to reduce the fever by paracetamol as well as sponging. And convulsions, we have to give diazepam. Then fluid electrolyte balance, imbalance has to be corrected with fluid. Acidosis also has to be corrected. So that is happening in cerebral malaria, but no need of any corticosteroids. So quinine, it is used for uncomplicated chloroquine-resistant malaria as well as complicated severe malaria, including cerebral malaria. Then what is the reason for this cerebral malaria? Cerebral malaria, how it happens? There are two theories: mechanical hypothesis and cytokine storm hypothesis. Nowadays, you know very well what is the cytokine storm, because in this COVID, this pandemic time, you know what is cytokine storm, etc. But I will just tell. Okay, so there are two theories for the cerebral malaria: mechanical hypothesis and cytokine storm hypothesis. Mechanical hypothesis means this the RBCs, it will be infected by the plasmodium because of the erythrocytic stage. It will be infected and it will be sequestrated into the brain vessels also, and that will cause vascular congestion, then localized hypoxia, and there will be breakdown of the blood-brain barrier, and there will be cerebral edema and a prothrombotic stage. So that is the mechanical hypothesis for cerebral, because of the plasmodium infected red blood cells. Then that is the number one. Number two, it is a cytokine storm hypothesis. Cytokine storm means because of the infection or the parasite, this infected red blood cells, there will be inflammation and the liberation of many cytokines like tumor necrosis factor, interferons, interleukin 2, 6, 8, 1, etc. And all these things cause the cerebral malaria. So there is two mechanisms: mechanical hypothesis and cytokine storm hypothesis. So that is the cerebral malaria. For this cerebral malaria, the treatment we are giving is quinine. So that was about quinine. Now coming to the other drug, it is proguanil or chloroguanide. It is a slow-acting erythrocytic schizonticide. But in India, it is not. It has only little role, so you will just skip it. Then another important drug is pyrimidine. Pyrimidine, this is very important. Pyrimidine, the mechanism of action is inhibiting the dihydrofolate reductase enzyme. So it will prevent the formation of dihydrofolic acid as well as tetrahydrofolic acid. In short, inhibit the folic acid synthesis. But this pyrimidine, it has got a high affinity for the plasmodial enzyme. That is plasmodial enzyme because it has got 2000 times greater affinity for the plasmodial enzyme. So it will be inhibiting the folic acid synthesis in the plasmodium. So like that, it will prevent the, damages the plasmodium. Then but we have seen one drug. Can anyone tell me which is the one antibacterial drug which is inhibiting the dihydrofolate reductase enzyme? Can anyone tell? Hello? One antibiotic which has got a sequential blockade, dihydroteroate synthesis and dihydrofolate reductase, and it inhibits the folic acid synthesis. Antibacterial. We have seen another anti-leprotic also, but in the beginning we have seen one antibacterial, another drug. Can anyone tell? No? Hello? So should I call out the names? Grishma. Grishma?
Yes, ma'am.
Can you tell which is the drug?
I don't remember, ma'am.
You don't remember. Anyone in the class remembering? No one. Okay. Have you heard of co-trimoxazole? Yes or no? Grishma. Have you heard of co-trimoxazole? That also you don't remember. Okay. Then we will. I will show the next slide. After we will come to that. So okay, this is. So we are talking about. We are dealing with this pyrimidine. It inhibits the dihydrofolate reductase enzyme and inhibits the formation of folic acid. So this it is a slow-acting erythrocytic schizonticide. Then pharmacokinetics, its absorption is very slow, but it is good only. And the adverse effect, when we see it is safe only, but it can cause megaloblastic anemia and granulocytopenia if it is given in higher doses. But it can be treated with folinic acid. So I was talking about pyrimidine. Then this pyrimidine, usually it is combined with some sulfonamide drugs. Sulfapyramine, that is SP. It will be written S/P. It is used, or dapsone, for the treatment of falciparum malaria. So sulfonamide, pyrimidine combination. So this, that is what the sulfonamide, it is having the action at the first level, that is dihydroteroate synthase enzyme. Then the pyrimidine, it will be acting on the dihydrofolate reductase enzyme. So there is a sequential, 2 steps are actually blocked if we are combining pyrimidine with sulfur drugs. So if you are giving only single drug, it is slow acting, but if you are giving combination like a sulfonamide pyrimidine combination, it is having good sequential block, and the combination is fast acting also. So it is used for the clinical curative for Plasmodium falciparum. So this is the drug I was talking about. That is the co-trimoxazole. I am not talking about the antimalarial drug. I was telling there is one drug that inhibits the same mechanism, sequential blockade of the dihydroteroate synthase and dihydrofolate reductase. That is sulfa-methoxazole and trimethoprim. This combination we have studied in the first class, in the beginning classes, antibacterial. It is the co-trimoxazole. So here also it is a sequential blockade, and pyrimidine also there is a pyrimidine and sulfonamide, if it is combined together, it is having a sequential blockade. So that is very effective for the treatment of falciparum malaria. Okay. Now this is one trade name that is fancied at the drug name. Just for your information, I just kept. Then there are certain sulfonamides, sulfadoxine, sulfamidopyrazine. These are all combined along with this pyrimidine because they are all long-acting sulfonamides. But the problem is sometimes it can cause, because if you are giving this combination of pyrimidine, even pyrimidine itself also can cause Stevens-Johnson syndrome and exfoliative dermatitis. Mainly it is because of sulfonamide, but pyrimidine also can cause, but mainly due to sulfonamide. So that was about pyrimidine. Now we are coming to another very important drug, that is the primaquine. Primaquine, yesterday we have seen it is used for the radical cure of malaria. Radical cure means it will be acting in the exoerythrocytic, pre-erythrocytic cycle, and it will prevent the relapse of the relapse. So that is why it is called radical cure. Usually we will be giving the erythrocytic schizonticide drug followed by this radical cure, so that the malaria will be totally eradicated. Whichever dormant forms that is occurring in the liver, that also will be totally removed. So that is why we are using radical cure, that is primaquine. But for Plasmodium falciparum, in the pre-erythrocytic stage, that is in the beginning stage, that also it is acting. But the exoerythrocytic, that is after the erythrocytic stage, there will be an exoerythrocytic stage which causes the relapse. There, that is not happening in Plasmodium falciparum. Okay, that yesterday we have seen already. So we will come to primaquine. Primaquine, so it is having the effect on the primary as well as secondary hepatic phases of the malarial parasite. Primary means it is before the erythrocytic cycle stage, and secondary means after the erythrocytic stage. Then it is also so it is a gametocidal also. So it is a radical cure. Gametocidal hypnozoids means that is a dormant forms. It is kept that is effective. So primaquine, it is not an erythrocytic schizon. It is for treatment, for the removal of the parasite from the blood cells. It is not possible, but from the liver and other tissue it is possible, and it is also a gametocidal. Now we will see the mechanism of action. What is the mechanism of action of primaquine? What is the mechanism of action? This primaquine, this generates, when it is given to in the body, it generates some reactive, the oxygen species, oxidative species. So ROS, reactive oxygen species, or the oxidative species. This actually disrupts the electron transport in the plasmodial mitochondria. So that is primaquine. So primaquine, intraparasitic or toxic oxidative species. Reactive oxygen species will be liberated, and that will disrupt the electron transport in the plasmodial mitochondria. Okay, so that is primaquine. Again, pharmacokinetics, it is readily absorbed. It is given orally only. Adverse effects. Adverse effects, it can produce some abdominal pain and gastrointestinal upset, and also dose related. If it is exceeding, it can cause hemolysis, methemoglobinemia, tachypnea, cyanosis, etc. All these effects are because of the oxidant, because it causes the liberation of reactive ROS, reactive oxygen species. And those who are having disease-free deficiency, they will be highly susceptible. So that is the one important aspect about primaquine. Then passage of dark urine. For quinine also we have seen it is because of the dark urine. It is because of the hemolysis. So this primaquine also can cause passage of dark urine because of the hemolysis. That is happening only in the high dose. If it happens, immediately primaquine we have to stop it. and it should not be given during pregnancy. So pregnancy, if the patient, if they develop malaria, you should not give Primaquine in pregnancy because fetus is always G6-ready deficient. So they may develop hemolysis. So don't give during pregnancy. Now, in which all conditions the Primaquine is used? So we have already seen it is given for the radical cure of malaria, relapsing malaria, that is Vivax and Ovel malaria. And this dose you have to study. It is a dose 50, at least remember this, 15 milligram per day. A dose 15 milligram per day for 2 weeks, that is 14 days. 15 milligram per day. Children, it is 0.25 milligram per kilogram per day. So this is easy to remember, 15 milligram per day for 2 weeks. But this should be given after the full curative dose of chloroquine or any other blood schizonticide, and after that only or simultaneously along with also we can give. So it should be given for 2 weeks at least along with the schizonticide, or after, once it is just over, next day onwards we have to give Primaquine. So it will eliminate both the exerythrocytic as well as the erythrocytic phases of the parasite because we are combining schizonticide. And then, but before starting, we have to see the G6PD status of the patient. Otherwise, if they are G6PD deficient, they can develop hemolysis, and it should be taken along with food to reduce the side effects. So we have seen that falciparum malaria, there is no exoerythrocytic stage, but because there is a pre-erythrocytic stage. So WHO now gives that we have to, they are advising to give one single dose, 15 milligram for falciparum malaria. And Primaquine also can be used in the case of pneumocystis jirovecii pneumonia, that is given along with clindamycin. So it is a radical cure for the relapsing Vivax and Ovel, 15 milligram per day for 2 weeks. Then next drug, it is tafenoquine. Tafenoquine, it is another anti-relapse drug that is like Primaquine, but and it is having a long T-half also. So it is a single dose that is enough. Primaquine we are giving for 14 days, 2 weeks, isn't it? Because in the its T-half is only 6 to 8 hours. But here you can see it is the T-half, it is very long, that is 14 to 19 days. So we can go for a single dose. This again, it is a radical cure, tafenoquine. So I think you understand. Now we will go to the next drug. Oh yes, 2 more important drugs. That is doxycycline and clindamycin. This, you know, they are all antibiotics. They are weak erythrocytic schizonticide. So we have seen in the beginning low efficacy anti-malarial drug. So under that this comes weak erythrocyte. These are having only erythrocytic schizonticide action. Both are weak erythrocytic schizonticide property because this is given along with either chloroquine, quinine, etc. But it is not given singly. Now coming to the very important and the latest and safe drug, that is the Artemisinin Derivatives. Artemisinin Derivatives. So this artemisinin, it is an active principle that is obtained from a plant in China. Chinese, that is, they use for the Kungaso. That is this is the medicine that is extracted from this plant. That is same plant. It is the Artemisia annua. Artemisia annua. It is a Chinese plant. So they were using this this extract, that is Kungasu, for malaria, and now they have developed Artemisinin derivatives from this active principle of Artemisia annua. It is not Kungasu, it is another product. And this is effective. It is a sesquiterpene lactone endoperoxide, and it is active against all the resistant Plasmodium falciparum and also all other species. It is effective. So this is one of the drugs that is again. Why we are not? I was thinking all the plants and herbs are in China only. So why can't we develop some drugs from India also? So I am just giving you some idea when you pass out, you do some researches on the herbal plants in India also and come out with some drug for important. So when you become doctors and do some research at that time, now itself we can do some researches and find some drugs, because whenever we go through different products, almost everything it is coming from China. Even our present situation also, it has come from China. So you can, I'm giving you this one. So you do some research and find out some medicines from the herbs that are available. Lot of herbs are available in India also. Plants are available. So you do some research. Okay. Will you do? Is anyone interested? Hello? Hello? Are you interested or not? No one?
Yes, ma'am.
Yes. Who said this? Hello?
Yes, ma'am.
Who was responding?
Amda.
Amda. Okay. So at least Amsa responded. No boys from the boys' side. No one is interested in research. See, people are finding out many drugs, medicines. Why can't we also find out some drugs? Others.
Yes, ma'am. Yes, ma'am.
Will you be an inventor of any drug in future? Will you try?
Let's think about that.
You are thinking. Okay. Okay, then you can think. Because not all, some drugs it is developed in India also. Many drugs, we are actually taking the drugs from that was developed outside, isn't it? So we also should find out some drugs. We are having a lot of herbs, plants, trees, etc. And other people, they are finding out. So we should also. Okay. Okay then. So Artemisinin derivative, it is obtained from the Artemisia annua. Then, so this is again, this Artemisinin derivatives, they are rapid blood schizoidicide. Main action, potent and rapid blood schizoidicide. So if you are giving this artemisinin immediately within 24 hours, that is in 1 day or 2 days, there will be parasitemia clearance compared to chloroquine or any other drug. And it is this is effective from the ring form of the parasite to the early schizon. So it is having a good action. It is having a broadest time window of antimalarial action. We are talking about artemisinin derivative. There are different derivatives. We will see different derivatives. The artemisinin itself, it is poorly soluble in water as well as in oil. So it is insoluble in water as well as oil. So some derivatives have been invented, that is artesunate, and that is soluble in oil, whereas artesunate sodium, it is water soluble. So artesunate. Then there is another active metabolite that is liberated in the body, that is dihydroartemisinin, DHA, dihydroartemisinin. Then, okay, there is one thing, one important thing that was developed in India. Yes, we are something we are doing. So there is an injectable compound, Arteether, that is IM in oil. This was produced in India. Arteether, it was an injectable product, and also one oral compound, Arterolane. Arteether and Arterolane. These have been developed in India. So Arteether, it is IM, that is parenteral. Arterolane, it is developed here as the oral. Okay, so artesunate, Arteether, Arterolane. All these drugs are collectively called artemisinins. So I was telling it is a potent schizone as well, and but it won't kill the liver forms, that is exoerythrocytic sites. That stage it is not effective artemisinins. Okay, So the artemisinin derivatives, they are artesunate sodium. That is the water soluble. This is the oil, soluble in oil. Artemether, that was not told. Artemether is there. Arteether and arterolane. Arteether, arterolane. These two are which are developed in India. Now we will see what is the mechanism of action of this artemisinin derivative. So this is here also some reactive, highly reactive free radical species have been formed. So this artemisinin, this drug, they contain one endoperoxide bridge inside that. So when it comes joined with the heme, there will be ferrocyan mediated ferrocyan of heme. It will cause the cleavage of this bridge, endoperoxide bridge, and highly reactive. This reactive oxygen species will be liberated, and this actually causes the lipid peroxidation and damages the endoplasmic reticulum and causing the lysis of the parasite. So here again, there is a reactive oxygen species. It is liberated. That is when there is a ferrocyan mediated cleavage of the endoperoxide bridge of the artemisinin compound, and that there is liberation of reactive oxygen. So at least you remember there is a highly reactive free radical species. It is liberated, which causes the lipid peroxidation and damages the endoplasmic reticulum and causing the lysis of this parasite. That was the first thinking, and now they also found out that there is another mechanism also. That is called PF-ATP6. That is a plasmodial sarcoplasmic endoplasmic calcium ATPase. So there is an enzyme. So this is also inactivated. This artemisinin free radicals, this will inhibit the plasmodial sarcoplasmic endoplasmic calcium ATPase. This is also inhibited. So at least you remember they form some highly reactive free radical species which causes the lysis of the parasite. Highly reactive free radical species. Okay? Do you understand?
Yes, ma'am.
Yes.
Yes, ma'am.
So always this others and some other person, I don't know who is that, I didn't see, is responding. No, this Aishwarya, did you understand?
Yes, ma'am.
Yes, okay. So I can ask you questions. I think that was the last slide. Okay. Again, the malaria, it will be continued. So shall I close the PPT? I mean the slides. You want to see it again? No.